The topics for today's discussion will be esophagus, and we'll be discussing reflux, esophagitis, Barrett esophagus, and a few tumors of the esophagus, mainly the malignant ones. Now, coming to esophagitis, there are a few types of esophagitis, which is actually inflammation of the esophagus. And the most common cause, which we actually all suffer, is something which is because of the reflux of the gastric contents into the lower part of the esophagus, which is called as reflux esophagitis. And that particular clinical condition is called as GERD, which stands for gastroesophageal reflux disease. In some books you may even find GORD, because that O will stand for esophagus, which starts with O, right? So there's some things which, so don't get scared when you see GORD in some of the books. So it's the same thing, GERD or the GORD, which is also called as reflux esophagitis, which may actually lead to Barrett esophagus. And Barrett esophagus, not the apostrophe S one, but the Barrett esophagus is something which we'll be discussing in a while. Apart from that, we have some chemical causes. The people who have attempted suicides, they have ingested all kind of things like acids and alkalis and even furniture polish, so they do get esophagitis if they survive. I mean, if they are successful in their attempt, they won't get esophagitis, but if they have an unsuccessful attempt of suicide, they definitely would lead to a chemical esophagitis. Apart from that, there are certain infectious causes of esophagitis as well. Now, coming to reflux esophagitis or the gastroesophageal reflux disease, the main thing what happens in this case is decreased lower esophageal sphincter tone. As we have discussed earlier, that the lower esophageal sphincter is not an anatomical sphincter. You don't really see a lot of muscular fibers over there, so it is just a sphincter which is having a functional property. So in case there is a decreased LES tone, the gastric contents will definitely move into the lower part of the esophagus or the distal part of the esophagus and will lead to inflammatory changes. People who have hiatal hernia, in which the part of the stomach is above the diaphragm, they will also have reflux esophagitis. They may also suffer from reflux. So the same thing, in which the lower esophageal tone is again one of the causes. In those conditions, when you have slowed reflux clearing, when the things go inside your esophagus, they go all the way up into your esophagus, and there is a slowed reflux clearing, even that. So in that case, the gastric contents are in contact with your esophagus for a longer time, so this will lead to esophagitis. Those conditions in which you have a heavy meal and the things which and all sort of things which can delay the gastric emptying, all these conditions will again lead to esophagitis. In some cases, you may have a reduced reparative ability of the gastric mucosa, which will also lead to reflux esophagitis. There will be eosinophils, which will be followed by neutrophils, and then some chronic inflammatory cells in the form of lymphocytes will be seen. Certain reparative changes in the form of basal zone hyperplasia, because the upper zone is being sloughed off, or it's being having a lot of inflammation and injury, so the basal zone will undergo hyperplasia, and there will be some lamina propria papillae elongation, which will also be congested in the form of hyperemia. Here you can see this type of mucosa is a typical, this whole thing is a squamous cell. And if you look very carefully, and if you look with a pathologist's eye, you can see a few dots over here. There are a few here, one here. There are a few dots over here, over here. You can see this one. You can see the dot which are present there. There are a couple of the dots here. Very subtle infection, inflammation, but the main thing is that you have this inflammation in the squamous cell layer, which you normally would not expect, right? Squamous cell layers are completely devoid of any inflammatory cells. Here you can see again, this is squamous cell mucosa, and you can see there are certain cells, and these cells are nothing but they have bright orange or brick red color granules. Yes, these cells are eosinophils. Again, these cells should not have been present in a squamous layer, but in this case you can see both photomicrographs, they are present inside the squamous layer, so that again signifies a lot of inflammation. The complications, they may be bleeding, which may be superficial. If it is quite long-standing, it may lead to strictures, and of course towards the end it will lead to Barrett esophagus, and that Barrett esophagus will come up, will actually come with its own gift, regarding which we shall be talking in a short while. Now coming to the Barrett esophagus, now we actually know that the Barrett that the esophagus is having a thing called as a squamocolumnar junction, right? The squamocolumnar junction means the squamous part of the esophagus and the columnar part of the stomach. So that squamocolumnar junction is an important transition zone. So when this squamocolumnar junction starts moving a little up, that means the columnar epithelia is now coming and replacing the normal squamous epithelia of the esophagus. We call it the Barrett esophagus, which in this case, there's mainly what happens is there is intestinal metaplasia of a normally squamous esophageal mucosa. We know the definition of metaplasia: when one adult type of epithelium is replaced by another adult type of epithelium. So in this case, the squamous esophageal mucosa is being replaced by the columnar gastric or the intestinal type of mucosa. Remember that the presence of the goblet cells in the esophageal mucosa is quite diagnostic. I mean, nowadays they say that the Barrett esophagus, the diagnosis of Barrett esophagus is basically based on the histology, when you can see a few goblet cells, along with that endoscopic evidence of Barrett esophagus. So the single most common risk factor for esophageal adenocarcinoma, this can lead to esophageal adenocarcinoma, because there is a squamous metaplasia, and that metaplasia will lead to dysplasias which can be mild, moderate, and severe, which can lead to carcinoma in situ, and towards the end the patient may be suffering from the esophageal adenocarcinoma. 10% of the patients who are having reflux esophagitis or who are having gastroesophageal reflux disease may be suffering from Barrett esophagus. So that does not mean that everybody who's having a heartburn or everybody who's having reflux esophagitis will get adenocarcinoma. It is just a pre-malignant condition. The Barrett esophagus is a pre-malignant condition. It will just increase the risk towards adenocarcinoma. So the main thing is that there is a breach of the gastroesophageal junction or the squamocolumnar junction. So as per the definition, it is the replacement of the normal distal stratified squamous mucosa by a metaplastic columnar epithelium, which may contain some goblet cells. Reflux disease is something which predisposes the patient towards Barrett esophagus. Males are more commonly involved, and the process, the evolution is that you have a reflux esophagitis or GERD, which will lead to inflammation, which may lead to ulceration, which will lead to reepithelialization, and finally there will be change in the form of metaplasia, in which the squamous cells will be differentiated towards columnar cells. Now, though they are having an intestinal type of metaplasia, they will not have any absorptive function. That means it is a completely non-functional intestinal type of mucosa. It will just look like intestine, but it will not have any absorptive enterocytes. And if it leads to high-grade dysplasia, the chances of adenocarcinoma rises to almost 30 to 100-fold. Now, that means it is an important condition which we have to look for in the biopsy, so that we have to search for any changes in the esophagus, to look for any changes which may show evidence of metaplasia. Grossly salmon pink velvety mucosa, which will be seen between the smooth pale pink esophageal squamous mucosa and the more lush light brown gastric mucosa. It may go all the way up as tongues, irregular circumferential bands, or as islands. On microscopy, there is again changes of metaplasia, in which esophageal squamous cells will be converting themselves into metaplastic columnar epithelium, and you have to look for some changes which may show evidence of dysplasia. These changes, if you see that means there are increased chances of patient getting an adenocarcinoma. This is how it may look like. Now, if you look here very carefully, this particular area, this is a razor sharp area. This is the normal squamocolumnar junction, right? This is the squamocolumnar junction. This is the squamous, the pale pink squamous cells, and this is the pink velvety mucoid gastric mucosa, which is mainly lined by the columnar cells. So this is the squamocolumnar junction or the gastroesophageal junction, right? Now in this case, if you see very carefully, the point where this arrow is pointing here, this is the point where your normal squamous columnar junction should have been, but in this case it has moved all the way up till here. Here you can see that it is an irregular, jagged, something like this. If I am able to follow it, this is an arrangement which you can see over here, right? This is quite jagged and it is moving all the way up, and you can also see some areas in which you can see some punctate hemorrhages, small hemorrhagic areas are also seen. So here we know that there is replacement of this area, which normally should have been a squamous area, by the columnar cells which have moved all the way from the stomach towards the esophagus. Now why it happens? We know that squamous cells are quite resistant to abrasions. They can take care of the frictional things, but they are quite sensitive to acid. So in this case, when the contents of the stomach from here, they move all the way, they keep on refluxing towards the distal part of the esophagus. The distal part of the esophagus is now in a continuous acidic environment, which it is not used to be in, right? So they are going to convert itself into a type of epithelium which is resistant to the acid environment, and that type of epithelium means something which can produce mucus. So that is why they change themselves from squamous cells to columnar cells, because the function of the columnar cell is to produce mucus, and that is why they also have goblet cells. Goblet cells is something which contain a lot of mucus. Goblet cells look something like this. They have a shape of a goblet, like the wine goblet, right? This is how they may look like. So here you can see it is moving. So in this photograph you can see an endoscopic view, and here you can see this could have been the normal squamocolumnar junction over here, but now in this case it is moving somewhere up, right, in the form of tongues, the small area which is moving up over here. This is again a normal area, this is a normal area, but this area, this whole area over here and this area over here is something which has moved up from the normal squamocolumnar junction. So this is a case of Barrett esophagus over here and over here. Now what do you see here? On left side you can see a very nice arrangement of squamous cells, right? All these are the squamous cells. Everywhere you can see squamous cells, but here you can see they are turning into the columnar cells. If you tell me that this is from the normal squamocolumnar junction, I will believe you, but if you tell me that this is from the place which is, let's say, somewhere from here, if you say that this has been taken from here, then I'll be quite worried. Then I'll be thinking of Barrett esophagus rather than a normal gastroesophageal or a normal squamocolumnar junction. In both cases, if you take the biopsy from here or you take the biopsy from here, they both will look the same. So we need to know the clinical diagnosis. We actually need to know clinically from where this biopsy has been taken. If it is taken from here, it's absolutely normal. If it's taken from this area, this is something which will raise some eyebrows and may lead to Barrett esophagus. And you can see here a lot of columnar cells. All these are the goblet cells. They contain mucus. You can see some congestion over here. You can see some inflammatory infiltrate. All these are the lymphocytes which you see here. All these are the glands. Normally we do not expect glands inside the esophagus. Whatever glands which we have, there are very few glands which can be seen in the proximal and the distal part, which are there. Not many, a few glands are there, but so many glands, that means there is some kind of metaplasia going on. Along with that, a lot of inflammation in the form of chronic inflammatory cells, and all these are the goblet cells. If you want, I can I can put it down over here. Is the pen? Yeah. So all these are the goblet cells. This is the squamous epithelia. This is columnar. These are the glands which you can see here. This part is congested, and all these areas here, over here, over here, over here, over here, all this is inflammation. Of course, inflammation will be part, as this is going to be one of the components. One of the components will be inflammation in this case, right? So this is how it may look like. Again, now at the bottom, a beautiful layer of squamous cells, nicely arranged, no problem. Everything is perfectly whatever way it should be. You can see some submucosal areas, you can see some muscular areas, you can see a few glands over here, but they are the normal submucosal glands. Now if I come and tell you that this is from esophagus, you will say no, this cannot be esophagus, because esophagus is completely lined by the squamous cells, and these are the columnar cells. So in this case, so you have to believe me that if this is definitely from esophagus, so in that case you will say, oh, if it is from esophagus, then it has to be a Barrett esophagus, because I can see a few columnars, a lot of columnar cells over here. I can see a lot of glands over here. So this is definitely a case of Barrett esophagus if this thing is seen in the esophagus. And if you look over here, you can see tall columnar cells, you can see some inflammatory cells. All these are tall columnar cells. This looks like a goblet cell, not very sure, but all these are the tall columnar cells, right? These are actually inside an esophagus, so definitely this is a case of Barrett esophagus. What do you see here? You can see some areas of dysplasia, right? There is some kind of a scrambled arrangement. The cells do not look exactly the same. Some are dark, some are light. You can see some prominent nucleoli over here, right? These are prominent nucleoli. You can see some multi-layering over here, isn't it? You can see some inflammatory cells, which is a normal component. Along with that, you can see some mitosis. All these are the mitotic figures. You can just put it over here. These are the mitotic figures. This one, these one are the so in this case you can see a lot of dysplasia, right? Now coming to the tumors, they can be benign, as we know, they can be malignant, and the malignant tumors which we shall be discussing are the squamous cell carcinomas and the adenocarcinomas of the intestine. Of course, we know that the squamous mucosa is the mucosa which lines the esophagus, and adenocarcinoma is seen in columnar cells. This is the cells which lead to formation of glands, but in cases of esophagus, we don't have the columnar cells. So adenocarcinomas will be seen in the setting of Barrett esophagus, and they won't be seen in the setting of it won't be seen otherwise. Now, if you know the normal histology of the esophagus, you know there is a mucosa, you know there is a submucosa, you know there is a muscularis layer, you know there is an adventitia, right? So we know that everything can get involved in case of neoplasia. Since you have the smooth muscles, you may have leiomyomas, you may also have some fibrovascular polyps. Polyps are some kind of outpouching. That means there's going to be a kind of outpouching, a polyp formation, which will be having a fibrovascular core. A polyp should always have a fibrovascular core. If it doesn't have a fibrovascular core, it is called as a pseudopolyp. That means there should be some kind of vascular blood supply which supplies to these polyps, or else they won't be called as the polyps. They're called as pseudopolyps. They may look like polyps, but they're not actually polyps because they do not fit into the definition of polyps. That means they should have a fibrovascular core. Condylomas can be seen, which are seen because of human papilloma viruses. Any squamous cell in your body can get affected by the condylomas. You have fat, So you may get lipomas. You have fat in the esophagus, so you may get lipomas. In some cases, you may have some granulation tissue, which is also akin to a pseudotumor. Coming to squamous cell carcinomas of the esophagus, common things which can lead to squamous cell carcinomas are nitrites and nitrosamines. Betel, yes, betel nut is something which is again quite implicated in the causation of squamous cell carcinoma. Certain fungi in the food, tobacco, again our old friend and an enemy, right? So this is something which is going to be seen in a lot of cases of squamous cell carcinoma. Alcohol is another one. What about esophagitis? Can it lead to squamous cell carcinomas? No, esophagitis will not lead to squamous cell carcinomas, because esophagitis is something which is going to lead to adenocarcinomas. You can see some esophagitis, because if you are having all these things, there may be some esophagitis, but that is not something which is going to lead to squamous cell carcinomas, because esophagitis is mainly which is going to cause adenocarcinoma. There are few more risk factors which include alcohol. Apart from alcohol and tobacco, poverty, caustic esophageal injury, achalasia cardia, Plummer-Vinson syndrome, frequent consumption of very hot beverages, and previous radiation therapy, which mainly involves mediastinum, they can also be an important risk factor to the causation of squamous cell carcinoma. There's some countries which are having high incidence are Iran, Central China, Hong Kong, Argentina, Brazil, and South Africa. That would be for your information. HPV virus, human papillomavirus, has also been implicated in the causation of esophageal squamous cell carcinomas. In this photomicrograph, we can see the morphological evolution which may be seen in squamous cell carcinomas. You can see there is dysplasia, which may lead to carcinoma in situ, and if it infiltrates, it leads to an invasive metastatic squamous cell carcinoma. Over here, you can see a nice squamous cell layer, and here you can see a lot of dysplasia. We don't care about dysplasia here now, because we have a gland, we have a nest of squamous cells, not glands. We have nest of squamous cells which have gone all the way down into the submucosa. That means they have invaded. So once they have invaded, we don't have to talk about dysplasia. So we don't have to talk about carcinoma in situ. This is definitely going to be an invasive metastatic carcinoma. Most of the squamous cell carcinomas of the esophagus, they are present in the middle third portion of the esophagus, which is quite in contrast to the adenocarcinomas, which in the setting of Barrett esophagus will be seen in the lower third. But in this case, they are commonly seen in the middle portion of these lesions. They generally appear as small gray-white plaque-like areas, and they may grow into large polypoid masses, and they may obstruct. They may actually protrude into the lumen, and they can obstruct the lumen, right? And they can become like fungating polypoidal masses. In some cases, they become ulcerated, and there will be diffuse infiltration of the esophageal wall. The way they can cause thickening, they can cause narrowing of the lumen, and they can cause quite a rigid esophagus. And these cancers may also involve the surrounding areas, like they can involve your lungs, and they may cause pneumonias. They may involve the aorta, and if they erode into an aorta, they can cause a severe bleeding, because the patient will bleed to death, or they can involve the mediastinum or the pericardium. Most of the times they are quite moderate to well differentiated, like means that if you are able to see a few keratin pearls, that means this is something which is a moderate to well differentiated squamous cell carcinomas. They have a lot of lymphatic blood network, which actually promotes circumferential and longitudinal spread of these tumors. The most common site, if the tumor isn't seen in the upper one third of the esophagus, they will favor the cervical group of lymph nodes. I would better write down over here. If they involve the upper esophagus, they will go into the cervical group of lymph nodes. If they involve the middle third, they will mainly involve the mediastinal, uh, paratracheal and tracheobronchial group of lymph nodes, and if they involve lower third, they will go to the gastric and celiac group of lymph nodes. That means these are the areas where these tumors are going to metastasize, and we know that squamous cell carcinomas, for that matter all carcinomas, they actually favor the lymphatic routes, whereas all sarcomas, they favor the hematogenous route. So they are going to be having a lymphatic spread, they will having a lymphatic metastasis. If you see over here, we can see, what do we see here? We see a lot of dysplasia, right? The normal basal cell layers are not uniform. The basal cells have gone all the way up till the superficial layers. So all these are basal cells, and you can see the cells are of different shapes and different sizes. Along with that, you can see a few areas where there's a lot of mitosis going on, right? So this is a case in which dysplasia is occurring, and this dysplasia sooner or later, if you do not follow up properly, will lead to a squamous cell carcinoma. This is an X-ray picture of a barium swallow, and you can see there is an obstruction. Just looking at these pictures, we cannot really differentiate between a squamous cell carcinoma or an adenocarcinoma unless we know the clinical history and other investigation results in these patients. So you can see here there is an obstruction over here. The barium cannot pass through this area. Same thing over here. The barium, it is not able to pass through. There are some signs which are mentioned, which I will not go into the details because that's pure radiology. Over here you see this looks like quite a normal squamous cell layer, and suddenly when we go towards this side, if we call it the east coast and this is the west coast, if the moment we reach this west coast, the cells have become darker, they have become more blue, right? And at the same time you can see the cells have gone, again they might be dysplastic, but we don't really care. We don't have to worry about dysplasia because we are seeing invasion in this area. We can see a lot of squamous cells which have gone deep down into the submucosal layers, into the wall of the esophagus. So this is definitely a case of squamous cell carcinoma, which is metastatic, which can be metastatic. Next topic is, and the last topic for the day, is adenocarcinoma. Now I'm going to ask you, what are the top 5 causes or the top 10 causes of adenocarcinoma? They are always going to be Barrett esophagus. So they are the most common cause of adenocarcinoma. I don't know why it's not staying back. This is how it actually evolves. You have a squamous epithelium, you have esophagitis in the form of reflux esophagitis or GERD, and slowly it will have metaplasia. The squamous cells will be replaced by these columnar cells, and these columnar cells will have certain areas of dysplasia. Now when these things happen, when this moves from this stage towards this stage and finally towards this stage, it should accumulate a lot of mutations, right? There should be a lot of mutations which should actually occur during these areas, which may involve TP53 or which is also called as P53. So they should be involved. There should be multiple mutations which keep on accumulating as the things move from Barrett esophagus to dysplasia, from dysplasia to a carcinoma, which is an adenocarcinoma. Here you can see there's an actually all these esophageal adenocarcinomas, they most likely occur in the distal 1/3 of the esophagus, as we have discussed earlier, and they can also invade the cardia of the stomach, so the upper part of the stomach. They can actually go into the cardia of the stomach. Now earlier lesions, the same thing which we have discussed in squamous cell carcinoma, they can appear quite flat, they can infiltrate diffusely, they can ulcerate, they can form large protruding cauliflower like exophatic masses, or they can invade deeply down into the walls of the esophagus. If we see in this photograph, this pale area which you can see here, which is pale glistening area, this area is the squamous cells. All this is the squamous mucosa, and the moment you see all this is quite a yucky thing to see, right? This is an exophagic mass which is quite red, and you can see this part is the stomach. You can actually see the rugae of the stomach. All these are the rugae of the stomach, and it is actually going all the way deep down into the stomach part, into the cardiac part of the stomach. So this is the thing which is the adenocarcinoma, and if you take the biopsy from there, this area, this is how it is going to look like. You can see some glands which appear okay over here. They're looking this plastic over here, and if you see here, all these glands have invaded down into the lower zones. That means this is definitely a malignant tumor which has gone deep down into the wall, and this is a in this case this is an adenocarcinoma. On microscopic examination, you may also see some changes of Barrett esophagus which may be present adjacent to this tumor, and these cells will produce a lot of mucin and they will form a lot of glands, right?